board. John, every time. All right, I do see some
Good
people.
reminder.
So we are just going to wait maybe 30 seconds or so, and then we'll get started. We're just going to let people get settled in. Okay, well, we'll get started. It is 7 o'clock right now. So I want to welcome everybody to this week's virtual meetup hosted by the Epilepsy Foundation of Wisconsin. Thank you so much for being here. We're very excited to do this again this week. The topic tonight is women and epilepsy. But before we get into any introductions or we get into our topic this evening, I'm just going to do a few housekeeping items first. So first of all, we are recording this VMU, so you can see this. It'll be posted up on our website by next week. You can go back if you want to listen to it again, or if you want to refer anybody to it. We always put our videos up for, just for our education. So just know that it will be up on our website in a few days. And then also attendees on this call, you are muted and your microphones are off, but we do encourage questions. So feel free to ask throughout the presentation, that's okay. But we will do Q&A at the end, and you can do that by using the Q&A button or the chat button, whatever you prefer. It doesn't matter. John and I will be monitoring the questions that come through, so please submit them there. And I also want to mention, we do have an email that you can send questions to if you think of something after the call is done tonight, or if there's just something you would rather ask, not during this time, that's okay. And John can type that in the chat section as usual. It is connect@epilepsywisconsin.org. So you can use that email and we will get the answers to you. I'm trying to think if there's any other housekeeping things. I don't think so. So to start off introductions, for those that don't know me, my name is Alicia Thompson. I am the program manager here at EFW. And we also have John on the call, who I'll let you introduce yourself.
Evening, everyone. My name is John Mirasola. I've worked at the Epilepsy Foundation since about 2013. I work mostly with communications and client support services.
Great, thanks, John. And like I said, John and I will be monitoring those questions that come through. So with us tonight, we have Dr. Ann Josiah. She is from the University of Wisconsin Hospitals and Clinics. And I know she's going to get her PowerPoint that she has ready to go for us. But Dr. Josiah, I'm going to turn it over to you. We're very excited to have you, and thank you so much for being here.
Well, thanks so much. Glad to be here. I'll just briefly introduce myself first before the screen is filled with my PowerPoint. I am Dr. Ann Josiah. I use she, her pronouns. I currently am working at UW Health in the epilepsy clinic, and I do mostly outpatient epilepsy, some general neurology, and then also do the inpatient services, read EEGs. So many patients with epilepsy might see me in both of those locations, either within the clinic or we all share the duties of taking care of our patients when they get admitted to the hospital for epilepsy services. And in particular, myself, along with Dr. Elizabeth Felton, co-run the Women Plus Epilepsy Clinic and help people who menstruate or who have the capacity to become pregnant with various issues or hormonal changes that might affect their epilepsy treatments. And so that is what we are going to focus on tonight. And I'm going to remember how to use this particular video thing. Okay, here we go. Okay, it's always a little bit slower, and
that's okay.
Just enough to make you feel like you don't know how to use technology. Okay.
And we can see, so you're good to go.
Great. Okay, so here is my talk. I just wanted to include, I'm not going to be talking about any specifics about particular medications necessarily, or be providing any specific treatment recommendations that should be used on an individual basis. I think all of those should be discussed with your personal physicians. But I did just want to say, if you had looked me up online or something like that, I do have some affiliations with clinical trials with 2 companies for some investigational therapies. We do not have anybody actively enrolled at the UW currently, and this wouldn't affect any of the information that I'm going to be talking about tonight. I do want to go over just some brief definitions about epilepsy so we're all on the same page, talk about how epilepsy and hormones may have some interaction, medications that may be used to treat epilepsy, and some common interactions or considerations for this population, and then specific commentary about pregnancy, whether you are interested in that, interested in preventing that, considering planning a pregnancy potentially in the future, and then some things that might be important for you to be aware of if you find yourself pregnant, or if you're actively trying to conceive, what to expect throughout the pregnancy and postpartum period, especially if you are potentially being treated by in a more rural area where you don't have access to like a big epilepsy center like UW. So epilepsy is basically just the tendency to have seizures, and I'm sure most of you who are going to be on this particular call would be aware of that definition. So seizures are some abnormal electrical firing in the brain, and for the purposes of this talk, I am talking about epileptic seizures or brain-generated abnormal electrical firing that would require treatment with either anti-seizure medications, the use of ketogenic diet therapies, or other stimulation devices or surgeries. And really, we're just going to be focusing mostly on the medications that are the mainstay of treatment for epilepsy. So as you may be aware, there are different ways of categorizing epilepsies. And one of the most basic would be, do the seizures or abnormal electrical firing start in one location of the brain called focal seizures, or the entire brain called generalized epilepsies. And like I said, most of the time we are using anti-seizure medications in order to reduce the frequency or the potential for people to have repeated seizures. Sometimes this does require multiple medications or additional therapies like the diet or other surgical options. This may also be review for you all, but epilepsy is an all-time high in the US, and these are some older data from a couple of years ago now, but 3 million adults in the US are living with epilepsy, and then in Wisconsin, over 51,000 adults, and assuming that slightly greater than 50% or so of those people are women or women plus, you know, a lot of people are going to be affected by considerations for these hormonal variants and things like that we are going to be talking about. So what does make epilepsy different for people who menstruate or have the potential to become pregnant? So menstrual cycles with hormonal fluctuations, so the things that make people have an ovulatory cycle are mainly 2 different hormones, so progesterone and estrogen. And it turns out that estrogen is an excitatory hormone, meaning that when those levels are peaked, it actually makes your brain a little bit more excitatory, or have the potential to have an increase in your seizures associated with those estrogen peaks. And there's 2 peaks or 2 shifts in a monthly cycle where people might be having potentially more seizures. So one of those is associated with ovulation, and then the other associated with the onset of menses itself. A lot of people have some feeling that there could be an association with their menstrual cycle, but it really does help if you are thinking that this might apply to you, to plot out on the same calendar just the first day of your period, and then any seizures that you would have that month. And then if you can bring that, especially if it's like a couple months of information, to your physician or epilepsy provider, then they can look at that and help figure out if you fit into one of these patterns, which we call catamenial epilepsy. And that just means that there's a potential for you to have greater than 50% increase of your seizures during the times when you would have those hormone variations. So there's a couple different types. One is really association with having it during the ovulation. For most people, even if your cycle is really like a longer cycle, more than 28 days, or say it's 35 days, if you just would mark that first day of your period, most people ovulate 10 days prior to that, 10 to 14 days. So you can get a good idea just from that, like which type of the catamenial epilepsy you would have, if any of those. It turns out people are not quite as good at remembering. You think it's going to be something that you'll be able to remember, but when you come in to see your doctor, it's just going to be really hard to remember like all these different dates. So it's good to note it on the calendar, and then those patterns would be a lot more evident. And then the other thing is that people who have the potential to become pregnant could be impacted differently by medication. So either because they're trying to prevent a pregnancy and taking hormonal contraceptives, and the medications might have interactions with their anti-seizure medications, or they might be wanting or desiring a pregnancy, and wanting to make sure that the medication that's selected to treat their epilepsy is going to have the least amount of impact for risk of birth defects. And there's a term that we use sometimes called teratogenicity, or just the potential to cause problems with the fetus or baby because of the medications that mom is taking. Okay, so I talked about this already. I forgot that I put in some reminders for myself. So as I said, catamenial epilepsy, the best way to figure out if that applies to you is to really keep track of your seizures on a calendar, and then also that first day of your period. And we will talk about these other features of pregnancy prevention, medication interactions, and pregnancy. So a little bit more about the pregnancy and epilepsy. We'll go through each of the either pre-pregnancy, preventing pregnancy, and then if people who are actively trying to conceive, and pregnancy itself. So anti-seizure medications, many of them, or the bulk of them, get processed through the liver. And the liver is where hormones that, sex hormones that are involved in ovulation, involved in menstrual cycles, and also that are used to prevent those menstrual cycles from occurring, also get processed through the liver. And many of the anti-seizure medications that are processed in the liver can either rev up, we call it an inducer. It revs up these enzymes that metabolize other medications. It can make the levels of other medications drop. So it like chews up the medication faster, and you might need to be on higher doses of other things. Other ones can inhibit the enzymes from functioning normally. And so other medications that are also processed through that pathway, the levels can really rise. So in particular, we think about with pregnancy prevention, if you're on a hormonal contraceptive, like a birth control pill, then these medications that are revving up the liver function can chew up your birth control pill and make it way less effective. Now, as it turns out, birth control pills, many of us are aware, are not 100% effective anyway, even if you're taking them consistently the appropriate way. So then if you're adding this on top of that, your chances of having an unintended pregnancy can become quite high. And there actually was a study, I think it was in 2017, called, I have it listed down below, the Epilepsy Birth Control Registry, where they followed or they surveyed many women who have a diagnosis of epilepsy and had a pregnancy, either one or more pregnancies, while they were taking an anti-seizure medication. And women or people who were taking an enzyme-inducing medication, in addition to using a birth control method like a hormonal contraceptive, like the birth control pill, had the highest chance of having an unintended pregnancy. And so, our goal is really to give this information and make it available to everybody, so that you would have the foresight to know that there is a potential for that interaction. And anytime that you might be adjusting what type of contraceptive method that you're using, that you would discuss that you're on seizure medication with the primary care provider or a gynecologist or whomever is prescribing your birth control, in addition to discussing what birth control methods you are using with your neurologist who's prescribing your anti-seizure medications. The main, some of the medications don't necessarily have a direct amount of metabolism change, but with increasing doses, they can also cause a problem. So for example, carbamazepine is one medication that is known to be an inducer of the cytochrome P450. So that's that liver enzyme that chews up other medications. And we know that that can happen at any dose of carbamazepine. But other medications, for example, Topamax or topiramate, can at higher doses cause that enzyme to be revved up enough that it might impact the efficacy of the birth control. And I usually advise my patients that if you are ever on a stable amount of birth control and suddenly you're noticing like breakthrough bleeding as far as your menstrual cycle, to just assume that it is no longer effective and that you would want to use backup birth control, like a barrier method such as condoms, until you could address that with your gynecologist or whoever is prescribing your birth control. I'm used to asking for questions like as we go along, but I'm happy to answer anything at the end. So if you have questions about what I'm saying, or if I'm using crazy doctor words that don't quite make sense, you let me know, and I'm happy to clarify things. So in general, we really want people to be able to plan their pregnancy. So, some people are of the mindset, like if it happens, it happens, but certainly if you are desiring to not be pregnant, we want that to be, we want to make those wishes just as valid and come true as well. But we know that with these medications, and just in life in general, the unintended pregnancies do occur. And because the medications do have the potential to cause, with varying levels, the potential for birth defects, then we want to think about that even when we're prescribing a medication to a person who's taking a contraceptive method. And so if at any point you would consider keeping a pregnancy, if it was an unintended pregnancy, you would want to discuss with your neurologist what the potential impact on a pregnancy would be with the medications that you're taking. And one thing that we can do to reduce the risk of certain birth defects, primarily neural tube defects, which is how the spinal cord is formed. We can prevent problems with spinal cord formation issues like neural tube defects by taking a sufficient dose of folic acid. And so in people who are taking their contraceptive or using a contraceptive method, but are taking medications that might be higher risk for birth defects, I usually have my patients take folic acid maybe a higher dose if they're on multiple anti-seizure medications, or ones that have higher risk for birth defects. So if there are all these potential for birth defects associated with the anti-seizure medications, then why are we recommending that people continue to take anti-seizure medications should they become pregnant? So the reason is that the person carrying the pregnancy would have the potential for trauma associated with, big seizures, loss of consciousness, but also the risk of sudden death and epilepsy can be higher if they're having seizures during sleep, generalized convulsions. All of those things can increase risk. And then risk to the fetus if the person carrying the pregnancy is having frequent seizures, especially with generalized convulsions, anything with loss of consciousness or falls. There's risk for trauma, issues with the placenta remaining attached appropriately to the uterus wall, fluctuations in the mom's or the person who's carrying the pregnancy in their oxygenation levels can cause problems with the fetus heart rate. And then the more seizures that are had throughout the pregnancy, there's increased risk for small for gestational age infants. And there's one study that showed that the repeated seizures can potentially have an impact on the infant's IQ later on as well. So in order to have the healthiest baby possible, we want to make sure that those seizures are well controlled to reduce the risk of all of these things for both the person who's carrying the pregnancy as well as the infant. So one way that we try to figure out which medications might be the best during pregnancy is using this information gathered from the North American Anti-Epileptic Drug Pregnancy Registry. So this registry is not like register for your presents because we're going to buy you something when you have this baby, but is a registry of people who are pregnant and are on either one or more anti-seizure medications through their pregnancy, and just gathering information about what happened during the pregnancy. Was the baby healthy? Were they healthy? How were their seizures controlled? What other medical problems came up? And they compare the people who are taking the anti-seizure medications to both an age-matched person who is not on any of those anti-seizure medications, and then whenever possible, a similar person within the family of that individual who's taking the anti-seizure medications, to try to account for potential genetic factors that might be associated with higher rates of problems with the infants. So if there's a tendency within one family to have this genetic abnormality, we don't want to falsely assign that to the medication and have people worried about taking a medication that might otherwise be safe. So we're trying to account for all of those things. And it's a really great thing if you are pregnant, then we encourage people to register so that they can provide more information that we can use in the future. And this is how we're able to tell people about as much as we know now about the use of these medications. We try to, and I say we, meaning all of us neurologists that treat people who are pregnant with epilepsy, but really this is run out of Harvard in Massachusetts. So they are gathering all this data and sort of tabulating all these things, and have been doing so since 1997. There are similar registries around the world, and the data is very similar among these. There's like 5 different registries around the world, and the data has been very similar for all those main centers. So based on all this information, we can sort of stratify which medications, so figure out these medications are slightly higher risk, these medications are slightly lower risk, and then advise people how to potentially change the medications that they might be taking should they be desiring a pregnancy. we can't always change things. So as you might know, if you have had very difficult to treat seizures and are requiring multiple different anti-seizure medications in order to be seizure free, it might be in your best interest to stay on the medications that you're on in order to remain seizure free throughout the pregnancy. Somebody who was started on a medication that might be higher risk, who has never been on anything else and only had to take a small dose of this medication in order to control their seizures, might desire to switch a medication to one that has less risk and ensure that they are seizure free on that medication for several months or so prior to becoming pregnant. Usually we don't advise making a medication change once you already know that you're pregnant, because by the time most people are aware that they're pregnant, it's already about 6 to 8 weeks into the pregnancy, and many of the major organ formation has already taken place. So trying to make a medication switch at that time would just sort of expose you and the infant to more medications. But if we're trying to be proactive about it, we try to, ideally, we would like to do so 9 to 12 months before any intended pregnancies or trying to conceive actively, because we know that for 90% of women, however well controlled your seizures are for the 9 to 12 months before you're pregnant is similar to the 9 to 12 months of the pregnancy, or 9 months of the pregnancy, and then the postpartum period. So we like to have everybody be as close to seizure free or seizure free if possible. So the good news about women or others who might become pregnant with who have epilepsy is that the risk of major malformations, so birth defects, has really declined. So from the 1970s, it was 20% of women had infants that had some type of issue. And so this ranges from heart issues or those spinal cord issues, like I had mentioned, all the way to a cleft lip or cleft palate or something that would require just a minor surgery to repair. And then also includes just small for gestational age infants. But because of the awareness of which of the medications might be more problematic and the preferential prescribing of the ones that are less problematic, trying to use the smallest doses and the fewest number of medications as possible to control seizures. And then also the use of folic acid supplementation has reduced those risks down to 3.5%. So that's very similar to just the general population. Anybody who gets pregnant has a risk of having some type of issue with the baby. Usually the rates, depending on which articles you read, are around 1 to 2%. So 1 to 2 women out of 100 might have a baby with some type of abnormality. And among women with epilepsy, it's probably that 3 to 4%, depending on what medications they're taking. So I think that that's really good news. The overwhelming majority of women who are pregnant with epilepsy are going to have healthy babies, healthy pregnancies. So I had already said before that we would expect a pregnant person's seizure control to be similar to what they had experienced in the 9 to 12 months preceding the pregnancy. And we do recommend continuing the medications to maintain that degree of seizure control. We know that throughout the pregnancy, there are a lot of metabolism changes. Your kidneys are filtering things faster. The volume of your blood supply, I cannot speak apparently. The volume of your blood supply gets bigger. So the distribution of the amount of medication that you're taking is just spread over a larger volume. And also there can be changes in how your liver is processing. And so all of these things can cause the amount of active seizure suppressing medication to be lower in your body, even if you're taking the same dose throughout the pregnancy. And so for a while, the thought was, well, we should monitor some of these medications that are processed through the liver at least once a trimester, but we were falling behind in staying ahead of breakthrough seizures. And now the thought is that if we monitor people once a month, then we can be proactive about noting small fluctuations or small dips in the anti-seizure medication level and adjust accordingly so that we're not leaving the person exposed to having a breakthrough seizure. So this is of all the times we do not want a breakthrough seizure during pregnancy. We also know that many people during pregnancy might have issues with nausea, vomiting, maybe keeping their medications down. There might be other, additional stress as you're planning for this infant, excuse me, and then sleep deprivation, not just for the postpartum period, but can also really be affected throughout the pregnancy as well. And for many people, disrupted sleep or sleep deprivation can be a big trigger for their seizures. So those things also would need to be taken into account, and potentially medications be adjusted so that the person can remain seizure free. Following the pregnancy, if there was adjustment throughout, which is pretty common. So for some medications, it can be 2 to 3 times. By the time you're at the 3rd trimester, you might be on 3 times the amount of your pre-pregnancy dose and have like the same level of medication. And so if there is an adjustment that's especially that notable, we would often need to make a plan for following delivery of the baby. How are we going to reduce the medications down? I like to try to be a little bit proactive about that and discuss it at an early 3rd trimester visit and provide a letter to the obstetrician that's caring for the person that is carrying the pregnancy, as well as have the patient themselves have that letter. Used to be like, oh, pack it in your hospital bag, but probably now just having it screenshotted on your phone. So in case you're not delivering at the location that you expect, or if you have a very rapid labor or something like that, and you're not able to bring all the stuff that you had planned with you, that you still have that written documentation about how things were going to go, and who your contacts are for the clinic that's managing your anti-seizure medications. Sometimes we don't taper the medication all the way back down to that pre-pregnancy level, because once you're caring for the infant, sleep is very likely to be disrupted for at least several months, if not longer. And so I usually make a plan for just a slightly higher dose to give a little bit extra cushion, and then sort of just checking in at that, I call it like the 4th trimester, so that first like 3-month postpartum time. Is there any good sleep happening? And if not, let's just stay on that higher cushion dose until baby's sleeping through the night consistently and things like that, which can be a little bit longer. With that sleep deprivation, because it is such a big trigger, we like to advise our patients to avail themselves of assistance or help if they have it at all available. Having somebody that can help feed the baby at least once through the night, potentially, to get a good 4 or 6 hour chunk of sleep can be really helpful. Sometimes that does go back to the question about breastfeeding. So for the bulk of medications and for the bulk of patients, if they are willing and able to breastfeed, it is recommended despite the use of anti-seizure medications. If there is some concern about the baby not waking up enough to eat or not gaining enough weight, then sometimes that would need to be reconsidered. But because of sleep deprivation, sometimes people do try to supplement with formula for a feed, or do an additional pump of breast milk and have that stored so that they can get a longer chunk of sleep. And then you just have to weigh that risk and benefit between breast milk supply and then the quality of sleep issue. If somebody is having ongoing seizures or had breakthrough seizures, either during the pregnancy or during the postpartum time frame. We do advise that when caring for the infant, you would avoid doing baths if no one else was around, and either doing a sponge bath or waiting until another person was available to help supervise that, to do changes on the floor as opposed to on a high counter, to try to stay on one level if no one else is home. So like not be carrying baby up and down the stairs, or if you did have to, actually using the car seat to transport the infant up and down the stairs. So that's just some of the things that we talk about and put in our after visit summaries for safety, including the standard things like not sharing a bed with the infant or sleeping with the infant, and other things like that. I think that is probably reaching the end of my planned chat, but like I said, I'm happy to answer any questions. And this is just a look at our women's epilepsy clinic. We do offer consultation. So if you do have a neurologist that you like in the area, but you had questions about medications because you're thinking about planning a pregnancy, or you're realizing that there's a fluctuation in seizures associated with your menstrual cycle and you wanted some thoughts about how that could affect your treatment, then we do offer like consultations in addition to doing ongoing care for people. So I will leave that.
Wonderful.
Happy to answer questions.
Thank you. Yep. So we do have some questions that came through. So just give me 1 second. I gotta open this up. All right. So this one reads, if the mother has epilepsy or the father has epilepsy, would it be passed on to the child if both parents have epilepsy or just one parent?
Yeah, that's a really good question. I mean, there are some types of epilepsy that we know have genetic components, but not all people who have epilepsy had a parent that had epilepsy. So it really depends on what type of epilepsy the person has. You might think that the risk might be slightly higher if both parents had epilepsy, but it's still not a guarantee. And the inheritance is not such that I could say like, oh, there'd be 25% risk if this parent had it and 25, like,
Yeah.
It's just so variable in how these different types of seizures or epilepsy tendencies are passed on, that we're not good at giving people specific amounts unless you knew that you had a specific type of inherited epilepsy.
Okay. Thank you. I want to go back to something that you just recently talked about, actually. So you talked about having maybe the mother have help with the infant if need be, especially if sleep deprivation was happening. Is there anything that you know of off the top of your head for resources that are available to somebody who fits this category? Maybe they don't have a family member who can necessarily help. I don't know if there's anything that you can share on that.
I am not sure. I mean, I guess that would just depend on like the local area. I'm thinking that if people didn't have family or friends that could really help with like that middle of the night feeding, it'd probably be a lot easier to get somebody to help with feeding during the day. And like maybe your best sleep while you're caring for this infant in this season of life is not going to be a nocturnal sleep or nighttime sleep, and you're just going to be somebody who like sleeps during the day. I bet you it would be a lot easier to get assistance at that time. But really just trying to be creative about how you're caring for it. And we fully understand that not every situation is perfect and ideal world. And some people are just going to have to cope with poor sleep for a period of time. And maybe they'll need to be on different doses of their medications in order to account for that.
Great, thank you. Let's see, are there certain types of epilepsy medications that are better or worse for someone who's trying to get pregnant? I know you touched on some of the medication stuff.
Yeah, I mean, so there's sort of groups of medications, in general, lamotrigine and levetiracetam have the lowest rates of problems with the infants. So we call it teratogenicity. So the risk of having an infant with a birth defect is a little bit lower for those medications. and there's sort of groups, but really it depends on what medications are controlling your seizures or what type of epilepsy you have. So I certainly have had many women who are on medications that have higher rates of uh, problems associated with them. So the one that people often think about is valproic acid, but it doesn't mean that if you have to take that medication because that's the only thing that is effective for controlling your seizures, it is still the overwhelming bulk of women or people who are pregnant on that medication are still going to have healthy infants. So I don't want it to dissuade people from taking the appropriate medication to control their seizures. So I think that's a really good question to consider along with your doctor, because it depends on how hard was it to control your seizures, and just be open. There's charts that are available from that North American anti-epileptic database that your physician should have access to, and then you could sort of like look at the list. What have you tried? What are you on? And is it worth changing your medications or not?
Okay, great. So just speaking of kind of going to the doctor and seeing your neurologist, so a woman who has epilepsy, who's diagnosed with epilepsy, how do I ask this? Do they have to go in for more appointments? Is there, more precautions that have to be taken rather than just the, like a normal checkup or whatever? Is that something, is there more doctor's visits, I guess, is probably the best way to ask.
Are there more doctor visits just because you're a woman?
No, just because so a woman who is diagnosed with epilepsy, just because, they are likely going to be on like anti-seizure medications, or I just didn't know if there was more.
Like is there additional follow-up?
Yeah.
Yeah, so not necessarily. I think it's just that if you are somebody who has these considerations, then when you are prescribed a medication, there should be a conversation about whether or not you are taking a contraceptive, and if you do have any plans to become pregnant, and just know that if you're considering a pregnancy, even if it's like 5 years from now, that you have a conversation with your physician that that's something that you hope for in the future, is whether it's not now or not, so that you can start planning what medications you might want to be on or not want to be on because of that.
Okay.
Yeah. One thing I didn't talk about, which is another consideration, is that some of these medications, especially the ones that rev up that liver metabolism, can also do the same to other hormones. Like vitamin D is actually a hormone that helps with bone health. And people can be at higher rates or have higher rates of osteoporosis or osteopenia, so thinning of the bones, and be prone to fractures if they're on some of those medications, or if you're taking multiple different anti-seizure medicines. And so it might be worth asking about checking calcium and vitamin D levels, especially if you're not being supplemented for those things. And if you've been on one of those medications for a long period of time, or if you're not sure, then asking whether you should be getting a bone density screen would also be something to consider.
Okay, great. Thank you. Looks like we have a few more questions. Let me just, somebody is wondering if you could kind of explain and talk about what is, I don't want to say this wrong, I think it's eclampsia. Yes, that's right, I think.
What is eclampsia?
Yes,
Okay,
if
so
you could kind of explain a little bit.
This is a disorder among women who are pregnant, and has the thing that links it to epilepsy or makes people think about epilepsy is that it's associated with seizures. So you can have elevated blood pressure, liver enzymes can be elevated. You can have a drop in your platelets, which is the part of our blood that helps it clot. And then, so that's sort of like the syndrome called preeclampsia. And then eclampsia is if you have all of those things, plus you're having seizures. I'm not an obstetrician, and typically this is a disorder that is treated by somebody who's an OB physician. But the mainstay of treatment for that is magnesium, and is not use of anti-seizure medications. Sometimes we do both if we're not sure whether the person also has epilepsy, but it's sort of a separate disorder. Even though the end result is having the seizure, it's because of all this other issue that's going on with the patient.
Great. Wonderful. Okay, thank you. It looks like there's another question. How does being polycystic cause problems with epilepsy?
So how does it cause problems with epilepsy? Patients who have polycystic ovarian syndrome or PCOS, there are some medications that can increase rates of that disorder. So valproic acid has an association with higher rates of having PCOS. It doesn't necessarily cause a difference in your seizures unless you're having unless your menstrual cycle is very impacted. So there's a big range of what can happen related to that disorder. But if you had a big change, like you're not having your periods or your periods are very irregular, and you were somebody who had seizures that were impacted by your periods, that could potentially have an impact. But you might want to consider being on medications that are not going to worsen that condition. So avoiding valproic acid potentially would be something to consider or discuss with your doctor.
Okay. Thank you very much. I think that is all the questions. I just have one more, just because smartphones are such a big part, well, technology in general is a big part of life nowadays. And there's a lot of apps out there. And in the beginning of the call, you talked about tracking is very important. Do you ever recommend, or do you know any that whether you have to pay or they're free? Is there any apps out there specifically for, menstrual cycle and that kind of stuff that you know of?
There are multiple different ones, like period trackers, that I don't know. I don't know if there's necessarily overlap. I think that you could make either like a My Seizure Pal, and then you could add in something that to you would indicate that you're having your period starting on that day. But I don't know that it would necessarily be something that's like fit in that way. You know what I mean? It might be like a symptom thing that you add in.
Yeah, just because you did mention, if you get asked the question like, when did your menstrual cycle start? I mean, and then you did mention, like you have to really think about it. There's dates, and so I just thought maybe a lot of people use, applications on their phone. So instead of writing it down, could be right in their hand when they go to the doctor.
Yeah. So, I mean, we have a lot of people that use My Seizure Pal. We do have, the old school printout calendars available that have like reminders about how to do that you could like fax in, and it could be part of your chart if you wanted it to be, if you wanted it to be able to be scanned and be part of your chart. That would be one way to go about it, because we can't scan your app, but certainly the app is more readily available. Yeah.
Great. Yeah. No, I was just curious. Thank you. It looks like somebody said that there is an app called Flow, FLO, just for anybody who's curious. All right. Well, I think that's all the questions for the evening. I don't see anything else. John hasn't said anything. So I think that's all of them. But again, just want to remind you guys that you can use that connect email that John typed at the beginning. If anything comes up after the fact, please feel free to submit questions, and we can get them to Dr. Josiah and then get the answers back to you. That's no problem. I want to say thank you, Dr. Josiah. Really appreciate you being on the call this evening. Thank you for your time. And everybody else, thank you so much. I hope you all have a good night.
Thanks. Bye.
Bye-bye.